everyone, Ms. Turbyfill here, and in this video I'm kind of going to go over some of the different tube feeding methods you can do, how you set it up, and some of the general supplies that you need. Before you get started doing a tube feeding, or if you're going to give medications, you always want to gather your supplies first. I'm going to kind of go over some of the supplies that you'll use. The first thing you'll need is what they call an irrigation tray or irrigation system, and it's pretty much a little box that has a container that you can use to fill up your water or tube feeding, and it'll come with a syringe. These are good for 24 hours or per facility protocol. I know where I work, they're good for 24 hours. So you just get a permanent marker, you can write directly on the bottle, or the box that came in, just write the date and time that you opened it. After that, you would need your actual tube feed that you're going to give to the patient. This is an example of what one would look like. They can come in cartons, they can come in cans. There's a bunch of different types of tube feeding. It kind of depends on your patient's nutritional needs. And the physician, or sometimes a dietitian or nutritionist for the hospital, will determine which is the appropriate type of feeding for them to get. If you're doing a continuous tube feeding on a pump, then you would get your bag and your tubing kit. This is the standard bagging kit that comes or goes with what we call the Kangaroo pump, and the Kangaroo pump is just the standard pump that a lot of facilities use to administer tube feedings. But it's a two-bag system. They connect at a little port down here, and it goes into one piece, and then it connects to the patient. You have a blue top bag, and this is what your flush goes into, so this is what you'd put the water in, and the purple top is what you would dump your tube feed into. Now, once again, blue is for flush, purple is for tube feeding. As far as how much to put in there, there's really no right or wrong way. I personally, when I'm filling them up, I fill it enough to last me my whole shift. So I'll kind of calculate out, okay, how much tube feed is my patient going to go through in the next 12 hours, and that's how many containers worth I'll dump in, just so I don't have to keep refilling it throughout the day. And then as a courtesy, I usually will top them off before I leave for the day, so the next shift doesn't have to worry about doing it. Just like your irrigation tray, these tubing sets are also only good for 24 hours. So new kits come with a label, so you just write on the label the date and time that you opened it. If for some reason you lost the label or you didn't come with one, you can get a permanent marker, write directly on the bag the date and time that the tubing was opened. So that way the next day they know what time it needs to be changed out. And these are what will go into the Kangaroo pump, which I will show you. So this is pretty much our Kangaroo pump, and I have a separate video for y'all to watch that's more up close. It actually shows me programming the pump and loading the tubing into the actual pump. So this is what it looks like. It'll connect on the back to your IV pump, if you can kind of see it in the picture here, and this is what administers their tube feeding continuously. Another part of my supplies I always like to get is a towel. Especially if I'm doing medications or a bolus tube feeding, and I like to lay that on the patient, kind of right on their abdomen, and kind of lay the tubing on top of it, just because sometimes contents will leak out and you just don't want to make a mess on the bed or on their clothes. So I've gathered all my supplies, and I'm going to get my tube feeding started. When I come into my patient's room, the first thing I want to do is I want to assess the site of the PEG tube, or the G tube as we call it. Now, patients will have these because they have some kind of nutritional deficit, if you will. Maybe they've had a stroke and they can no longer swallow, so they may have one of these tubes placed to be their sole source of nutrition. Sometimes patients who maybe have limited swallowing abilities or some other disease processes that's impacting their nutrition. Sometimes they'll also have these placed just for supplemental nutrition. But they'll be placed in the left upper quadrant of the abdomen. That's where your stomach is located. They're surgically inserted, and they're kind of stitched into the inside of the stomach. As a close-up, this is kind of what the tube looks like. Depending on the manufacturer, they may look a little different, but they're all pretty much the same or pretty standard. So on your tube, you have multiple ports. So you have these two white ports, which can be used to give medications or tube feedings through. Then you have this colored port, and this colored port's a little different. This actually inflates a bubble on the end of the PEG tube. So I'm going to show you. Get my syringe. All right, so I'm inflating this bubble right now. If you can see it getting bigger. It's kind of like a Foley catheter if you're familiar with how Foley catheters work. So even though it's stitched in, they also inflate this bubble, and this helps hold it in place. So say this is your stomach, you know, that bubble is keeping it kind of from being popping out of the stomach. Then you have this other rubber piece here called the bumper, and that kind of rests on the skin. So this is basically how your PEG tube or your G tubes are going to look. All right, so I've come in, I'm assessing the skin. So once again, this bumper that rests on the skin, if it rubs against your skin too much, it can actually cause skin breakdown, and you can actually get pressure ulcers underneath the skin. You always want to assess the site around it. If it's a newly placed PEG tube, you want to look for any possible signs of infection. If it's red, puffy, any swelling, any kind of abnormal drainage or odors coming from it, you just make sure the new site, the surgical site, isn't getting infected. So everything looks good, but before I put anything down my tube, you want to verify its placement. Now, if it's a newly placed G tube or even like an NG tube, they will do the initial verification through some sort of X-ray or radiology study to make sure it is in fact located far enough down in the stomach. But outside of that, there's two ways we verify placement. One way is to get your syringe, pull up to about the 30 ml mark, just full of air. Then you're going to put the syringe snugly into one of those ports. Now this is where you'd have your stethoscope on, and you'd listen, place your stethoscope right over the stomach, and you would slowly push in that air. And you should hear a swishing, noise of that air being blown into the stomach. If you hear that, then you know it's in the correct place. Another way to verify placement is still using your syringe. This time have the plunger completely down. And once again, you'll put it snugly inside the PEG tube. And this time you're going to slowly pull back, or what we call aspirate. And you're looking to see if you're pulling back any kind of stomach contents. And you're going to keep pulling back until you don't get any more. Sometimes you may only get a little bit, 20, 30 cc. Sometimes you'll get a whole syringe worth. But you'll pull it back, and sometimes some facilities will do what they call pH testing, where they get actual pH strips, and they'll dip it in the contents to make sure the pH level is consistent with what it should be in the stomach. But after you've aspirated your contents, you will refeed it to the patient. You don't want to discard it or dump it down the drain of the toilet. You want to kind of maintain your patient's balance. You're going to refeed it to the patient. Another reason we aspirate stomach contents outside of verifying placement is we're doing what we call checking the residual. And checking the residual is kind of monitoring how well they're absorbing their tube feeding. If I'm giving a bolus tube feeding, which I'll go over in a few minutes, every couple hours, I want to see how much they're actually absorbing. So I'm going to check the residual prior to giving it. Because this little can here is 250 milliliters. So if I give them this can at lunchtime at 12 o'clock and their next one is due at 4, well, when I come in the room at 4 o'clock, I'm going to pull back on my syringe. If I end up pulling out 220 milliliters of fluid or tube feeding, the patient's apparently not absorbing the feeding as we anticipated them to. So I'm not going to want to dump a whole other container on top of that. I'm going to notify the provider of the amount of residual I got, and from there they can either space out the tube feedings more, give the patient more time to absorb it, or maybe they need to decrease the amount the patient's getting. But that's another reason we aspirate stomach contents with a syringe. So I assessed the site, I verified placement through instilling air and aspirating stomach contents. But one more thing I want to do before I put anything down the tube is make sure my tubing is patent. And that just means is my tubing clogged or unclogged. So once again, you get your syringe, take out your plunger, and you're going to put it snugly in one of those ports. And when I'm holding my ports, I like to hold them where they connect together. It's because sometimes if you're holding it way up here, every once in a blue moon, it will get loose and pop off, and then you have tube feeding or fluid or whatever it is spilling out all over the place. So I like to hold mine where it connects. So to check, to make sure your tubing's patent, you're going to get your container of water, and you're just going to pour about 30 to 50 milliliters of water into your tube. I'm not actually going to do this mannequin. But once it's in there, you're just going to watch the fluid and making sure it flows down at a nice, steady pace. If it's going really slow or sluggish or it's not dropping at all, that could be a sign that there's a clog somewhere in the tube. So this one's nice and clear. You can see through it. Some of your other tubings, like the one I showed you earlier, is white and you can't see through it, so you can't always see if there's a clog. But if their tubing is clogged, you don't want to dump in a tube feeding or medications on top of that. Because one, it's not going to do the patient any good because it's not going to reach them. But two, you're just kind of financially wasting supplies at that point. So that's one reason we want to make sure our tubing's patent before we dump anything down it. All right, so I've assessed it. I've made sure it's in the right place, and I've confirmed that my tubing is patent. So now for your tube feeding, you always want to make sure your patient is elevated. If you're doing a continuous tube feeding on a pump where the feeding is going continuously for 24 hours or however many hours, the patient needs to stay elevated at a minimum of 30 degrees, but preferably anywhere from 30 to 45 degrees. And that's because they're at a higher risk for aspiration. So they're at a higher risk for that contents coming back up and going into their lungs. So that's why I want to keep them elevated at all times if they're on a pump. If they're getting a bolus tube feeding, which is where we're manually dumping it in every couple hours, you want to have them remain elevated for 30 to 45 degrees for at least 1 hour after the tube feeding. Give that tube feeding time to kind of start getting absorbed. So for the continuous tube feeding, like I showed you the 2 bags. Once you have your bags filled up and you have the tubing in the pump and programmed, which once again I'll show you on a separate video how to do that, you're then going to connect your tubing, which is a little purple port, and once again you're going to pick one of the ports on your tube and you're going to snugly push it in there, and once it's in there you then go and hit run on your pump, and then the tube feeding will start infusing to the patient. That's what a continuous tube feeding is. Now for a bolus tube feeding, which is a little different, this is the one that we do manually. This is where you'll get your syringe, you'll take the plunger out. I'm going to put my plunger snugly into my peg tube. Now, I've already flushed it and made sure it's patent, so I know it's good to go. So now I'm going to get my can of tube feeding, give it a few shakes, make sure it's kind of settle on the bottom. But then I'm just going to dump it into the open syringe. I'm going to let it flow down by gravity. And as it gets towards the end, I'm going to keep topping it off until the whole can is gone or however much has been ordered. And I'll let it flow in by gravity. You don't ever want to get the syringe and push it in forcefully or quickly. You want it to flow by gravity. After the whole tube feeding is done, I'm going to then get some more water behind it and flush behind it. And once again, you don't want any of that tube feeding stuck down in that tube. As far as how much you flush behind it, that's going to be a part of your order, which is going to be either done by the physician or the dietitian or the nutritionist. They'll determine how much tube feeding you're giving, how often, and what the flushes are going to be. So you're just carrying out their orders. But once it's been flushed, you'll discontinue, close your ports back up, and then just tidy them up, and then you're good to go for however many hours until your next round is due for the bolus tube feeding. So that pretty much wraps up the difference between continuous tube feedings and bolus tube feedings. And once again, you'll have a second video showing the Kangaroo pump up close and how to program it. Thanks. Alright, in this video I'm going to show you how to program and load the tubing into the actual pump. So this right here is your Kangaroo pump. It's a pretty standard pump that is used for administering any kind of continuous tube feeding. So on the side of your pump you have this blue door, and you'll open that. So here's your door and it opens, and it actually gives you a little diagram right there of how to load the tubing into your pump. But I'm going to take your tubing, and on your tubing here you have this little purple piece, and this is where the connector, these 2 tubes turn into one, and this is what you're going to load into your pump. So on this purple piece, you turn to the side, you see you have this little ledge right here. You're going to make sure this ledge is turning out when you put it in. So the purple piece is going to go down this first hole, and push it in, make sure it's, it's in there. And then the rest of the tubing, it's stretchy. You're going to stretch it down around that black wheel, and then you're going to drop it in from the top. So make sure, that's the important thing to know. If you try to put it in from the sides or the front, it's not going to go in. You have to stretch it up, drop it in from the top, and then it's in place. So once that's in, you can shut your blue door until you hear it click. So now we're going to proceed to turning the pump on, and we'll program our pump. All right, so I'm going to hit clear settings. Now right now it says set loaded. If I didn't have the tubing already in there, it would prompt me right now to put the tubing in like we just did. So since it says set loaded, the pump is acknowledging that the tubing is in place. So right now I'm going to start priming my order, and once again these orders are going to be determined by the dietitian or nutritionist or the doctor. So at first I'm going to put in the feed rate, which is how much the rate at which the tube feeding itself is actually going to go in, and once again that's going to be the bag with the purple top. So I'm going to hit right here where it says adjust feed. Alright, so you have feed rate. Alright, so now you have a bunch of place markers. You have 3 options. You have your hundreds place marker, your tens, and your ones. And right here it tells you 400 is the maximum amount you can do. I'm just going to put in a random rate. We'll say 70. So I'm going to my tens marker right there, that arrow, and hit it 7 times. So now I'm at 70 milliliters an hour. I'll hit enter. Alright, so my feed rate is now 70 milliliters an hour. That's what my doctor has ordered. This next option, the feed VTBD, you can click that right there, and it just pretty much you type in the volume to be infused. So a can of tube feeding is 250 milliliters. So say I dumped in 2 cans into that purple bag, I'd have a total of 500 milliliters in that bag. I could hit that button and type in 500. That just lets the pump know how much is in there. You do not necessarily have to program that. It kind of works similarly to an IV pump, to where if there's air on the line, the pump will know that, it will sense it, and it will alarm or letting you know it's empty. So you don't necessarily have to program that. So I'm going to hit done. So I program my feed rate. Now I'm going to do my flush. And remember, that's the bag with the blue top. That's your water. So I'm going to hit adjust flush. Alright, so you have 2 options. You have flush volume and flush interval. So I'm going to do flush volume first. And once again, all this is determined by the nutritionist or the doctor. So once again, I'm just going to put in a random number. We'll say 150. So I'm going to my hundreds place marker, hit it 1 time. So I'm at 100. Go to my tens place marker and hit it 5 times. Alright, so now I'm at 150 milliliters. So that's my flush. So I'm going to hit enter. Alright, so that's how much I'm getting, but how often are we going to do it? So now you're going to go down to flush interval. You're going to hit that option. Alright, so this is where we put in the amount of hours. And I'm just going to put in 4 hours. That's a pretty common flush interval for a lot of peg tube feeding. So once again, you have tens and your ones place marker. So I'm going to hit this 4 times. Alright, so make sure I have 4 hours. Hit enter. Alright. So now I'm going to hit done. I've programmed everything. Now before I do anything else, this is where you want to double check your order one more time against the actual order itself, or check the screen against the order. So I have a feed rate of 70 milliliters an hour with a flush of 150 milliliters every 4 hours. You want to make sure all that matches what's on the doctor's order. So now you're going to prime your set, because right now in all of your tubing, it's a bunch of air right now. So all that's just air. Now it's not going to necessarily hurt your patient to put air in it, but it could give them gas. They can feel a little uncomfortable. So, and also it could potentially give you an error message on the pump if there's nothing in the tubing. So we're going to hit prime pump. Now I'm not actually going to hit prime pump right now just because it's not attached, but you'd hit prime pump. And then you would hit auto prime. And when you hit auto prime, you will hear the pump start, the motor and the pump start working. You'll see the tube feeding and the flush going through the tubing. Once it's all the way down to the very end of the tubing, this purple tip here, sometimes it'll even drip out a little bit, and it'll automatically stop when it's done. You'll hit the done button. You will then connect it to the patient like we showed you in the last video. Once it's all connected, you will then hit the run button, and then it'll start administering the tube feeding. Now your pump will also track how much the patient's receiving. So as you can see here on the screen, it says 0 mLs fed. So that's how much of this tube feeding has been fed to them. And now it says flush, 0 ml flush. So as this pump is running, those numbers will change, and it will keep track of how much water and how much tube feeding the patient is getting.
Now at the end of your shift, you can clear this information out just like an IV pump, and you can type that into your intake and output. And then that way the next shift coming on can keep track of their own numbers. So you can clear all that out between shifts. So that in general is how you set up the Kangaroo pump. Now we're going to power it off, and that is done.